Welcome to the ASPPH Presents webinar, Public Health, Democracy, and How to Operate in this New Era. I'm Tim Leshin. I'm the Chief External Relations and Advocacy Officer here at the Association of Schools and Programs of Public Health, based in DC. Really excited to have you here. I know that over 1,000 people signed up for this webinar, so there's clearly a lot of interest. A couple of housekeeping items. This session's being recorded and will be shared afterwards online. So members of the press, if there's members of the press, they may not quote or report on this unless they get explicit permission from us, ASPPH, or the speakers. So please use the Q&A function when you submit questions. There will be ample time for Q&A later. And we'll address those questions at the end. If you have any technical issues, report them in the chat, please. Today, we're going to explore the impact of the new political landscape on public health and public policy, research funding, and higher education. We have three distinguished, excellent panelists with us today. I'm so pleased to have them. First, we have Mark Miandusky, partner at Cornerstone Government Affairs, and he'll share his insights on the impact of the election and healthcare policy shifts in the new public health priorities. Mark has been working for ASPPH, I don't remember, Mark, but at least 20 years, helping us advocate for public health and just been a real champion. Next, we have Dr. Danny Fallon from the Emory University Rawlings School of Public Health, who will discuss shifts in how we think about research and its relationship with the federal government, including issues like facilities administrative costs, which have come up recently. Finally, last but not least by any means, is our amazing advocacy chair for our advocacy committee here at ASPPH, Dean Boris Lushniak, who is professor and dean at the University of Maryland's Public School of Public Health, and he will discuss higher education policy updates and the enactment of strategies and policies related to how we're going to manage in this new environment. I'll just begin with a very brief overview. You know, we are definitely I've been doing this for well over 20 years, and we are definitely in uncharted waters. This is the most disruptive new administration that I've seen, and I'm not talking partisanly. I'm just saying they're doing a lot of things that are new, that are impacting public health, some of which ASPPH has pushed back on a bit. We were very concerned when data was pulled off the CDC website recently, and we put out a statement expressing our concern because data is the lifeblood of research for our members. Luckily, a lot of that data is starting to come back online, but it still was troubling. Recently, as I quickly mentioned earlier, there was a memo that came out from the NIH last Friday that said that the indirect cost rate, the facilities and administrative costs, would be capped at 15%. This again would be a major shift and really devastate the impactful research that our faculty and others are doing in public health, because those costs are real costs and they need that funding in order to do the research that is making an impact. So ASPPH, along with the AAMC and others, entered a lawsuit and received a temporary restraining order so that policy has not gone into place yet. There will be a hearing coming up next week in front of the judge on that. So we're seeing rapid change and rapid policy proposals coming out, and we're trying to do everything we can to, speak up for academic public health and make sure that the voice of our members are being heard, because we want to make sure that our members who are training the next generation of leaders in public health have the resources and the ability to do their job. And so we are super, super fortunate to have this great panel. I'm going to turn it over to Mark Miodowski first, who is going to really give us a sense of the lay of the land in Washington, and then we'll go from there. Mark.
Thanks, Tim. And I just have to reiterate Tim's word that we are in uncharted territory. I'll extend it back 2 more decades. I've been doing this for almost 40 years and going back to the Reagan era. And yeah, we've never seen anything like this. And I'll just give you the bottom line up front. I think, we're going to be in this kind of chaotic period from now until at least the August recess, and trying to engage the Congress is probably the bottom line up front, is that's what we need to be doing as schools. I know you have to run through your government relations offices at your institutions, but at your levels, collecting information about what you're seeing, what's going on, disruptions, changes. There might be opportunities, but there's also challenges and existential threats right now. And the Hill has to hear this, both red states and blue states. So far, we've got, this administration is clearly testing in a way it's never been tested before, the executive branch power relative to the congressional power. And, appropriations is key to that. When Congress appropriates money, they expect it to be spent according to those guidelines and appropriations bills. This administration is saying they don't have to do that. They're going to go to court to test it. So that's a fundamental change. We're seeing this play out with USAID right now. The president says they have power to, basically stop the funding, to freeze it, to, furlough everybody, to change, subsume USAID under state. You would normally think that Congress has to approve that. That's being tested, and we're seeing Democrats, raising a lot of objections to this kind of new process or change in the way, the process works. Republicans, by and large, are sitting by, watching, and letting it unfold. I mean, I think it's hitting everyone with, kind of the speed of a shock and awe plan that, is intended, that it's overwhelming to everybody on the Hill and, out in the field and in the executive branch agencies. Having the Doge come in as this new kind of third party, not federal government, agency people that we normally talk to, but a independent group of people that are making decisions rapidly about staffing levels and workforce and funding freezes, is something we've never seen before. And, that is causing quite a bit of chaos, because normally we would want to be talking to people, talk to the new political appointees, understand the new directions and priorities, and try to see where there's alignment, but where we can work together. But that's not happening right now. So maybe that will come about. RFK vote just happened a minute ago, and he passed, so he will be the next Secretary of HHS. We had one Republican, Mitch McConnell, vote against RFK, but all the Dems voted against him, and all the Republicans voted for him except for McConnell. So, that will be the next step. Now we will see operating divisions fill in with, the next layer. So the heads of CDC, NIH, FDA will, go in front of the confirmation process, get voted on, and then get into the agencies. And then we'll have a different group of people to talk to at that point. But right now we're still in sort of a blackout where we don't have the ability to talk to anybody. CDC is actually itself in a communications blackout that's still extending, where some of the other HHS optives can speak. So I'm going to try to run through a list of some of the top line things in just the 3 more minutes I have left, and then we'll try to answer a lot of stuff on Q&A. But yeah, I think the thing that hit most folks initially was the payment management system shutting down. That seems to have been turned back on. So grants, the immediately drawdown of your R01s, should be happening. New NIH grants are being approved, as we understand it. As Tim mentioned, there is a pause on the FNA cap, so that should not be being applied right now. Obviously we've seen, one of the other big unknowns that's going to need some sorting out is this sort of, the executive order on DEI and climate. What does that mean exactly relative to our work? What grants won't be funded or will be defunded or recast somehow? There is no definition. We've been trying to talk to people best we can at the agencies about, how are they defining this work, and it's, to be determined. The WHO freeze is affecting a lot of our schools. And that, pulling out of the U.S. from WHO participation, pausing that money. USAID, mentioned quickly, is being subsumed under the State Department. They seem to have the legal authority to do that, but they furloughed all the staff that, work in those missions and embassies, and they were saying they were going to keep the funding going, but the embassy staff were saying we need the USAID people to, administer these programs. And as you know, the USAID staff's been called home, from overseas postings, and the leadership staff have all been furloughed and cut off from the communications. And there is concern that CDC is next. The way it's being characterized is CDC going to get the USAID treatment? We don't know. We'll see. But that's kind of still coming. You'll hear the budget committees I'm kind of moving on to a couple of things. I'm just trying to get things on the table. The budget committees are moving forward with reconciliation process. The thing to look out for there, and that's going to come later in the year, is, some of our schools, our private nonprofits, higher education schools that have endowments, they're looking at the tax exemption status of that. And that could have, huge implications, obviously, similar to the F&A cap. These are kind of existential threats that are out there. On the appropriations process, the current funding under the continuing resolution runs out on March 14th. What they're talking about now is a full year continuing resolution that would largely be a freeze for programs at last year's level. But there's also this, because we don't have the Democrats aligned with the Republicans, and you still need 60 votes in the Senate to pass appropriations. If the Democrats aren't happy with the way the bills are being written, the next CR, there could be a government shutdown, and who knows how that resolves itself. There's federal workforce issues that are being dealt with. The next, obviously it's converting people to Schedule F. It means they can, career civil service people will be converted to at-will positions, meaning they can be fired. The buyouts are occurring. About 70,000 federal employees out of 2 million apparently opted for the, early buyout or early retirement. And then the probationary hires that hired in last year are all subject to being fired immediately. So there's a lot that's happening in the federal workforce. And then, I think on Monday, the president gave the DOJ committee authority to do RIFs, reductions in force. So that is still to be determined how that plays itself out. So that's a lot. I know we'll get into more in our discussion. But with that, let me turn it over to Dean Fallon. Thank you.
Thanks, Mark.
Thanks, Mark. Sobering updates, I think, for all of us. And so I'm just going to acknowledge, although in a webinar function, we can't see all of your faces, I am sending you virtual hugs and empathy for what is a challenging time for all of us engaged in public health in different ways. This is ASPPH meeting and or convened, and I've sat on the research committee for ASPPH since I became dean 2.5 years ago, and will get the opportunity to chair that committee coming up next month. And so the concept of how we function as academic public health institutions who do research in partnership with the federal government is something that I've been thinking a lot about, not only in my own role, but for all of us engaging in this together. And so I'm just going to mention 3 things that have been mostly on my mind in the last 5 days, 7 days. The list was shorter 6 days ago. And the first is what was mentioned, these executive order driven mandates that appear to restrict funding in certain areas. These include things like gender ideology, some aspects of climate justice, and then diversity, equity, and inclusion. The next thing, so we were already all grappling with how do we even understand that and move forward. And then last Friday, we all learned of the directive to cap IDC at 15% at NIH. And then lastly, I want, even though this is talking about research, I do want to remind us that there are many educational activities that we as schools and programs of public health are engaged in that are funded through research mechanisms, particularly for our doctoral and postdoctoral students, and particularly for things like diversity supplements. And so these restrictions are also affecting what some may see as our educational mission, but they really are one thing for a lot of the work that we do. So for the first, the executive order driven changes in federal funding. While there is currently a TRO, as was mentioned, and thank you in that case to APHA and several others who acted very quickly on the funding freeze, agencies are continuing the auditing process of looking at specific grants to know which ones of those they will then send notifications of termination or modification. And so while most of us haven't received a ton of these stop work orders yet, we're anticipating that those may come soon. And the challenge there was already mentioned is these are very unclear and vague in their description of what could be considered in violation of these executive orders. and it appears, for example, the diversity, equity, and inclusion one, the language around it really speaks to this idea of fairness in selecting who is hired, who is fired, who is admitted, those kinds of things. That's my interpretation, but it's based on the way it's written around kind of a civil rights perspective. So we can imagine that awards that really are about selectivity, based on some of the concepts that they mentioned, might truly be on the chopping block. What is confusing for all of us are you've seen these like circulating lists of keywords, and they include, things that are very generic, like bias and like the word female and things like that. I think we have to, in what we're preparing for locally, but I think what we need to talk about for ASPPH is standing our ground for the definition of the science of public health. And so what I'm focused on is paying attention to not over-interpreting violation of these executive orders, because public health research means looking at who is at risk, where they are at risk, why they're at risk, and what to do about it. And, we all know examples. An mpox outbreak that disproportionately affects gay men, then we need to focus on preventing disease in that community. Black women die at twice the rate of white women for breast cancer. So we need to focus on why that is and how we can improve that as a public health mandate. Farmers exposed to birds and cattle in the current avian flu outbreak, then we need to focus there. So these are just the work of public health. They are not about kind of selectivity of who gets hired, fired, that kind of thing. So that's one area that we're focusing on in terms of thinking about the threat to grants and contracts under those executive orders. For the second, which is about this IDC cap at 15%, it was helpful for me to sort of go back and remember, how did this ever come about? And so I would direct any of you to several recent writings that we could put in the chat about the history of IDC, or I think more aptly called F&A for Facilities and Administration. And as I understand it, after World War II, the US government wanted to become a sustained leader in science and discovery. And so options are build it yourself and have your own buildings and your own scientists, and some of the things that we did see during the war, or partner with institutions who do this kind of research, but on behalf of the government. So they chose the latter, and from the get-go realized you pay for the actual, consumables that are part of any one scientific project, but you have to have the buildings, and you have to have the people and the HR and the people who will look at compliance and regulation and all those things happening too. And those things are harder to attribute to any single grant or any single piece of work, because they're about the whole infrastructure being possible. And so you couldn't do that work if you didn't have that infrastructure, and somehow that infrastructure has to be supported. And so from the get-go, the government had this idea of, we'll fund line item things, but then we'll also give money because these universities are acting on our behalf to be the leaders in science and discovery. So that was the origin of it. And if you take that frame, it's very clear that we cannot do the research that we all do today without that kind of support for the real work of having facilities, having buildings, all those kinds of things, and also the real work of addressing and complying with regulations, of budgets, and all those kinds of things that those of us who do research know a lot about. So an immediate change, like going from an average of 50% across different universities, where those rates are different, but let's just say on average 50%, down to 15%, is a gross underfunding of those things that are necessary to move forward. And so I think us as a professional organization and as specific universities, we have to think about, how do we evolve this relationship between universities and government? We're clearly not going to go back to where we are right now. Whatever happens, there's a freeze in place now, but as was mentioned, this could come up in reconciliation. It could come up in new ways of budgeting. We have to be clear-eyed about what would be a better model. How can we innovate doing this differently? Should we be writing in things as line items and calling them, quote, direct costs? Should we be having some different kind of negotiation around what an indirect cost would be? Should we have a whole different model? Those are the kinds of things that I think we all have to grapple with and really think about right now, and lean into common ground that is, we don't want government waste. We're all taxpayers. We want to do this the right way, but we do need funds that will make us successful as discoverers and public health practitioners that make impact. So I'll end with just a little bit of things I said to my team this morning, and that's, to just acknowledge this difficult time, to allow ourselves the spaces to vent, to feel anger, to feel fear. I've heard people tell me they feel betrayed because of the work that they've done for so long on behalf of all Americans. I think we have spaces for that, but I also think we need to fill our spaces with grace, with support for each other, with empathy, and then with creativity. How do we move through this moment? And I keep telling our folks, it's a privilege to be leaders in this field in this moment, because we get to shape how we make it through this painful time and how we end up on the other side of it. We are part of that change of the architecture, I believe. I also talked to them about this kind of environment, both our colleagues in government agencies directly, but also us as academic public health folks, in lean times and with limited resources, can lead us. We're all so stressed, we're not sleeping, all those things. It can lead to infighting. It can lead to internal competitions, to being unkind to each other. And we have to really fight against that. Like, that would be a really bad outcome if we lose the ethos that is the field of public health, where we are mutually supportive of each other, where we are trying to figure out ways to be creative and help each other and help the public that we serve. So I hope we keep that as top of mind, that we're here to find collaborative solutions through this turmoil and build these relationships, create academic public health that will look good on the other side of this. And not give in to sort of doubt and skepticism and those kinds of things. And I know that's easy to say and hard to implement, but it's really what I'm thinking about right at this moment. And so wanted to share that with you. And then I'll leave you with, none of us were prepared. At least I don't feel I was prepared to handle this moment. I don't think anything in our past careers has been exactly this particular moment, but we do have things we can lean on. And I do think we are capable of making it through this moment. So thanks for the time.
Thank you so much, Dean Fallon. Really appreciate the first part about what's going on and the impact of some of these changes, but also your empathy for all of us who are living through the changes. So I'm going to quickly turn it over to Dr. Boris Lushniak from Maryland. Go ahead, Boris.
Great, thank you so much, Tim, and great words from Mark and from Danny, and I'll add to some extent a perspective on this. It was mentioned in terms of history, this unique time period, right? I'm going to use that term unique with a certain amount of leeway, right? But it is very unique, and I want everybody on this call to realize that we are under incredible amount of pressure, an incredible amount of change. And it's also pathways that perhaps we've never seen before, right? My own background, 28 years in government service, right? 27 years as an officer in the United States Public Health Service Commission Corps, 16 years at CDC, 6 years at FDA, 5 years in the Office of the U.S. Surgeon General. And then a time period at the Uniformed Services University prior to taking on this position as Dean of the University of Maryland in College Park, and that was 8 years ago. In that public health experience, in that public health career path, I've never seen this before, right? And so I got to tell you that this is shock, this is awe, this is something that I wish were a nightmare that we can all wake up from. And the reason I'm bringing emotion into this is I think it's right for us as scientists, as public health people, as people oftentimes who separate ourselves from the emotional aspect of this, is to basically say this is damn scary, right? What we're undergoing right now. And in essence there are some answers along this pathway. But first, let me talk about, right, what we were hit with, right? And we've already covered a lot of this, but specifically from the academic dean's perspective, right? What we've been hit with is a variety of things, and this won't be a whole laundry list, and I'll neglect certain things. But in essence, it is the curtailing of public health activities, right? We look at the federal government, and being a former Fed myself, is the sense is that we've looked at the federal government as a leader in public health. Yes, we can talk about the things that occurred in the midst of the COVID pandemic, things that happened right, things that happened wrong. But in essence, overall, there has been this activism for public health, for the good of the population, coming from within the US federal government. And now all that turns into a big question mark, doesn't it? The whole idea of public health priorities, right? The concept that all of a sudden we have changes going on. We can't talk about certain things. And those of you who have not seen this, right? I'll try to focus this on, let's see, it was focused there for a second. But in essence, this is a report, right? U.S. Senate Committee on Commerce, Science, and Transportation from the ranking member, Ted Cruz, that talks about DEI. But the title here is Division, Extremism, and Ideology. And in essence, it presents this concept of what the priorities have now shifted to. You know, I'll age myself, but saying that years ago, George Carlin had this famous album, right? The 7 words you can't say on TV. Now we have 20, 30, 40 words we can't say in public health. We can't say in research. We hopefully can still talk about it in the classroom, but we're worried about these words that in essence were public health priorities: environmental justice, diversity, climate change, racism, right? This is mind-boggling that in the academic realm, we are now afraid of saying certain things. So that's the category of public health priorities that are changing in these last few weeks. Public health activities, the communication from federal agencies, right? MMWR not being published for the week that it wasn't. Now it's coming back, but it's definitely censored to a large extent. We won't talk about certain things. The websites that have disappeared from CDC and from other aspects of the US government. The whole world of diversity, equity, and inclusion, right? How do we view that, not only within schools of public health, but within the whole academic realm? We see major shifts going on. We see this in the private sector as well, which doesn't bode well when major corporations are in essence walking away, the private sector walking away from activism in this realm. I just started here at the University of Maryland, a brand new undergraduate degree in global health. Took me years to develop it, right? It is successful. But I worry about that because the signal right now is that global health is less of a priority for this nation, right? The decision to pull out of the World Health Organization, the collapse of USAID in the midst of all this, right? What is this signal in the world of global health and our leadership, right? We teach our students about the importance of global health, and yet right now things are falling apart in front of us. Environmental health as a subject matter, things going on at EPA and obviously the climate change world. Research, as Danny has talked about, right? The influx of not only research topics, but the influx of influence on NIH and the 15% potential that coming down the line. And then 2 other categories that are really sort of earth-shifting, I think, from the academic realm. One is the leadership that's presented in front of us. Right. I'll tell you, you know, this whole idea of RFK Jr. as the Secretary of Health and Human Services, my home agency for 27 years of my life, is it's unbelievable. Right. And so how do we sort of alter that and the ramifications that come with that sort of leadership within health and human services? And then finally, you know, and this is a biggie for me, right, is the sense is this has been my career path, right, as a physician, public health practitioner, is this concept that all of a sudden the work that we're doing is somehow in the view of this outside world of leaders, it's become demonized, right? What is the importance of public health? Doesn't really matter. What is the influence of public health in the population around us? Is it good or is it bad? Are we portrayed not only as academic, you know, leaders who are now taking the wrong turn, but in essence, public health academic leaders who have been taking a wrong turn? It's a demonization of us, and we need to be able to battle this. So how do we deal with all these issues, right? And Tim had mentioned I'm the chair of the Advocacy Committee. First and foremost is the idea is that we can't just take this sitting down, right? That's not of who we are as public health people. And I encourage you all, right? We had an incredible influx of interest in this webinar, but I encourage you all to stay active, right? To become more active in terms of us making our opinions known. We can do it through our organizations, right? We are representing, I'm a board member of ASPPH. I'm also chair of the Advocacy Committee. So I'm a fan of ASPPH. ASPPH has done incredible things from an advocacy viewpoint, right? This idea of latching on, right, this past week onto the lawsuit that was put out by the AAMC was an important move. We had the board vote on this, right, virtually in an 1 hour time period, right? That was a sign of activism of us trying to get ahead of the curve on this. It's taking risks without a doubt, but it's important for us to be heard. So engage through your organizations, the work of the American Public Health Association, of many other organizations that many of us are part of. Let's support that work. We as individuals are still private citizens who have every right to turn to our representatives. We have Advocacy Day coming up on the Hill from ASPPH. That allows us to represent not only our institutions, it allows us to represent ASPPH, it allows us to represent ourselves. So that's a key component of activism. To a large extent, I do want to sort of close with two themes, right? One of which is I'm blessed to a large extent of being at the University of Maryland. We are a state that is upholding its values. I have a president and a provost who 2 days ago met with the deans. Multiple meetings have taken place, but that meeting in particular was very poignant. And the three messages that came from my leadership, and I would love if this were throughout the whole United States. I know it isn't. I know not everyone is blessed with having the environment that I do. But the three messages are, number one, uphold our values. Uphold our values, do not give in. Number two, stay the course with modifications where necessary. We're not here to become targets, but we want to make sure that we are staying the course. And then third, and Danny had mentioned about this, is we are a community. We're a community of public health people. Let's stick together on this. So this is really critical. Years ago, when I was in the Surgeon General's office, I occasionally had bad days. You know, there was crises, there was things going on. And one ritual that I had as the acting Surgeon General was I would take my younger officers on a particularly bad day and we would go for a run. Tim, you're a runner, you would enjoy this run because it went from HHS down to the Washington Monument, past that to the Lincoln Memorial. I would make the officers read the second inaugural address aloud, and we would contemplate it. And on the way back, we would stop at the Martin Luther King Memorial, and we would choose one of the inscriptions that are there. And on a really bad day, and I thought it was like the worst day in my life, not knowing what we were going to have these last few weeks, I happened upon this one. And this is a well-known Martin Luther King saying, but ultimately, and I will change, or I'll say, because it's been on my bulletin board since that day in the year 2010. And it says that the ultimate measure of a man is not where he stands in moments of comfort and convenience, but where he stands at times of challenge and controversy. That day with my young officers, I remember I was hit with that. It was a really bad day, and this was very apparent. We're now in a period of challenge and controversy. We can change that sense of a man to person. We can say that it all depends on how we're reacting right now. So let's have that call to arms here. Let's have that call for us to be able to fight for our values, support the administration where we can, but fight for our values where we must. Thank you so much.
Excellent. Thanks so much, Boris, for that call to action for all of our listeners here today. I think that's so important that, and I want to just reiterate the point that, members of Congress, they are there to represent all of us, and they actually really want to hear from their constituents, especially folks who are in a particular field, such as public health. And constituencies matter. When constituencies are talking to their members of Congress, they can have a huge impact. And I was glad that Boris talked about that. So Mark, I think I'm going to start with you, and there's some questions around RFK Jr. in the quick Q&A. Now, I know you said that he just was confirmed. Can you talk a little bit more about what will happen now at HHS and what you think are some of the likely things that new policies that he's going to be pushing?
Yeah, well, sure, I'll try my best, but
Yeah,
this is all very speculative. So, I mean, clearly we have, he obviously is the secretary. We need to fill out the rest of the operating division leadership positions, and that's usually the level that we, engage, as with programs where they run. So, Bhattacharya at NIH, Makari at FDA, and Weldon at CDC all seem like they're going to go through their confirmation process. They're kind of doing their Sherpa visits this meeting. They haven't had their hearings yet, but that's kind of the next step. We'll hear what they have to say about these agencies, operating division specific program priorities, just like RFK did and went through, the gauntlet on, being questioned about vaccines. We will have another round of that coming. With him specifically, obviously he's talked about a variety of things. We don't know how that gets implemented, so it'd be really speculative on how is he going to, do some of these things. I mean, he I haven't heard it reiterated, but they talked about major reforms NIH for attributed to him, 600 FTEs being eliminated. I don't know where those FTEs are, but the shift away from infectious disease and towards chronic at NIH, I don't know, where how that lands. But this DOGE, certainly, even though RFK is there, the DOGE is operating and making decisions. So the FNA cap that came down, as my understanding, it's been reported in the press this way that at 4 o'clock on Friday, NIH was told by the DOGE cap FNA today at 15% and, implemented on Monday. And, so RFK is going to be there, but, what role does Elon Musk and his team, still play? I mean, they're still very empowered, I would say. So keeping an eye on that. I did hear just a rumor that, when RFK gets confirmed, if he got confirmed, which he just did, has to be sworn in, that he's going to ask all the senior leadership across operating divisions to resign. Now, that's just a rumor that's going around HHS right now, but that's going to have profound implications, if that actually happens, and we have a lot of folks acting. So, you kind of have to talk to people that have like the political roles at this point, and people in acting roles aren't people that you can talk to that can make decisions. We want to engage on our priorities and find out where they're headed. And you can't talk to old political career people. You have to wait for the new political people to show up and have that conversation. So we're going to be looking for those opportunities going forward. But I don't know. It's hard to answer. Kind of like, here's what he's going to do now, because I think it's, we don't know what these other elements of the administration are wanting to do and what he will be told to do.
Yeah, no, I appreciate you being as speculative as you could be, Mark, because no one has all the answers, and there's a lot of unpredictability here. Dr. Fallon, it occurred to me that one of the things you were getting at this, but if you would talk a little bit about what you think the impact of some of these changes will be for students entering a program in public health and what you're hearing from your students. I thought that might be helpful for others to hear.
Sure. So I think the impacts are different for different kinds of students across our programs. Many of us in ASPPH have doctoral programs, and I think all have master's programs of some kind. So the doctoral students, those really are research students, and I should say DRPH. Doctoral students might be PhD students or DRPH students. For the PhD students, those really are research-funded studentships for most programs around the country. And so those have direct implications along the lines that I talked about before. But the practice-based degrees, the DRPHs, many of the master's degrees, I think the concern we're hearing from students is more about what does the workforce look like? What does the job market look like coming out of this? And I think that is a frank discussion that our career services and probably many across the country are thinking through. We had Ann Schuckett and Jim Curran, who were past CDC folks and was a past director, come and talk to our students a couple weeks ago. And their sentiment was, the work of public health is a career-long set of agenda, right? And the needs, the public health needs of our country and countries across the globe aren't going away. But who will be our employers, whether the employers are government-funded employers or nonprofits or for-profits or other kinds of entities, may shift around. But the work itself is not going away. And so what we've reminded folks of is it feels really heavy because it feels like if there's, lower numbers for CDC or lower numbers for NIH or USAID or others, that those jobs are going away. I remind folks, but the private sector, there are absolutely jobs, Booz Allen, McKinsey, those kinds of things that are giving the expertise that we have in schools and programs of public health. They're giving jobs like that because they need that subject matter expertise in the work that they're doing, and many other things in between. So I don't know if that's still a kind of superficial answer, Tim, but that's the thread of conversations that we're having.
Well, I think all of our institutions are struggling with this. There aren't a lot of answers at this point, but we do want to make sure that we're reassuring our students that, as challenging as the moment is, their career in public health will still be able to go forward. As you said, it's just a question of how, and they too, have the ability to make their voices heard, either local, state, or federally, about their concerns, and urging their legislators to be supportive of academic public health. So, Boris, there's a question in here. It's a little long, so I'm just going to quickly paraphrase it. And you sort of got at this, but if you could talk a little bit more, they're asking about, what is our leverage? What is the collective action that we can take in order to, as they say here, put pressure on government in order to protect the work that you all are doing? Can you talk a little more about that?
Let me unmute here. First of all, it's being vocal, right? The silence is not an option. I'm not sure, like many others, after the election, frankly, and I'm trying to be a nonpartisan here, although it's clear that I'm not succeeding in that. But I went into a hold mode, right? Which is, I don't want anything about the news. I'm not watching evening time stuff. I am disengaging, right? That was a reaction that is now over, and that reaction needs to be that idea of being vocal, leveraging, right? We are up against something that in essence it is the perfect storm to some extent. That's not a good thing, right? And in essence, it is we will view any complaints that we're having as self-serving, right? I.e., when you are getting an F and A of a certain percentage and it's being decreased, oh my goodness, look at the ramifications, but is it really about the money? We're going to be portrayed in certain fashion. I think we have to be consistent in our messaging, the importance of the public health mission, the importance of public health as a subject matter, and that public health ultimately saves lives, right? And I think that's a key component of leveraging, right? That at the end, we're not here to bring evil into the world. We're here to do good. And I think that's the leverage in terms of the public health mission. To a large extent, we sometimes preach to the choir here, right? It's easy for me to go to see the Maryland delegation, in essence, when we have our advocacy days, and they, in essence, are, for the most part, in agreement with my viewpoints. The harder aspect is, how do we get to people who don't have the same viewpoints? And again, the leverage here is, let's go back to the mission. Let's go back to what public health is. And in essence, to say, here is the aspirational aspect of how we bring the concept of health into the world. I also want to sort of dovetail into the previous question regarding, kind of the component of student activism, right? I hope every school of public health program, public health, has activist students, either organized or not. And we have to be able to look at that population, the next generation of public health leaders, to realize that right now we're expecting stuff from them as well. We're expecting vocal, representation from them. In terms of, again, from the previous question, is the sense that, I met with my associate dean for undergraduate studies earlier this morning. And the fear was, okay, how do we, as we're recruiting new undergraduate classes in, how do we speak with the students about public health? How do we speak with their parents who are now investing in terms of resources? And my child wants to be a public health person. Once again, I have to be realistic. I don't know in the next few years. I have many students at the master's level, the doctoral level, and undergraduates who have aspirations. I've always wanted to work for CDC. I always wanted to work for FDA. I want to be at NIH. I'm not saying that that's not going to happen. I'm just saying if you're graduating soon, that may have to be diverted a little bit, but the mission continues. We have incredible opportunities at the state and local level. We have incredible opportunities in the private sector, at the foundation level, et cetera, et cetera. The mission is still very clear. I think we have to focus and leverage the mission of public health, Tim.
Well said. Thank you so much. There is a question about international students. I know that there are a lot of international students that go to our schools and programs. Maybe I'll start with you, Mark, just in terms of what you are hearing in terms of any change in policy related to international students. I know those issues came up in the first Trump administration.
Yeah, we've not heard anything yet, but of course, with the focus on, deportation of people that are here undocumented, that should not touch our students. I mean, that is really where the focus is, and they don't have the capacity and the money to do what they want to do there. So I'm hopeful that, this stays, kind of off the radar for scrutiny and for potential changes in the way the relationships currently work. So nothing we've heard yet that would threaten that. I mean, we've heard schools warn students, like if you go home for Christmas, maybe you don't want to do that. You want to, stay here. You may not be able to come back in the country. So far, we've not heard that's happened. The people have not been able to, come and go back to their home countries.
Yeah. Mm-hmm. But it's certainly a legitimate concern.
It's a concern, yeah, but nothing I would say to take action on that I've seen. Yeah, I mean, I think they're Mr. Homan and Noam at the Homeland Security seem overwhelmed with what they have on their hands, and they're not getting around to the student visas at this point.
Yeah.
And on the other part of it, the extent it's been talked to by Ramaswamy and Musk, that they're for bringing in, people through the H-1B process to work in, kind of skilled areas. So I would hope that when we get to that discussion, that we're okay and we justify our what we're doing.
Yeah.
Training and educating students in a global sense.
Mm-hmm. I'm also wondering, Mark, if you could just say a little bit more about this quote unquote reconciliation process. We saw that the Senate Budget Committee moved their bill yesterday in committee, and we know that the House is trying to do theirs. Can you just give us a sense of the level of cuts that they're proposing in those proposals, and if we have any sense of the potential impact on public health?
I mean, one of the direct impact, well, I saw there's Medicaid flagged. I mean, Medicaid's clearly the biggest issue. I mean, it doesn't, affect us as, our operational funds, but certainly we all care about it. Medicaid's clearly on the table. So the level of cuts they're looking at is around $300 billion. So that, maybe back up a second. There's three parts to what they're trying to get done is, the House, this is what the Senate wants to do now, and they're leading. So let me just start with that is, defense, more money for defense and Homeland Security to do the deportation effort and, and kind of rolling back some of the Biden climate stuff. And then later in a second bill, they want to deal with taxes in the fall, and taxes where we get put on the table for like the nonprofit status. And so we're, for the earlier package, the pay fors is where we get into the Medicaid cut. So on the House bill, they want all this in one bill. So the tax bill with the, Homeland Security and defense money, and then pay for it. Just to extend the existing tax cuts from 2017 forward costs about $4.7 trillion. They're not going to pay for that with cuts. They're going to just say that's current law policy. We're just extending what the policy is, so we don't have to pay for it. So that's a scorekeeping, change from what the normal convention is. You'd have to have an offset. So that's good that we're not looking for 4.7 trillion in cuts. They want to do additional tax cuts, things for like restore some of the caps on salt the state and local taxes, property tax, are capped at $10,000, and so people who live in New Jersey, New York pay more than that in mortgage interest, and so they can't write that off. That's something that's a big priority for Northeastern Republicans to get that done. The no taxes on tips the president proposed, that's something that has to be paid for. So there's additional tax cuts. Going back to Medicaid, what we're going to see is instructions right like this week and next week from the House, this week from the Senate, how much the Health Committee, the Senate Finance Committee, Ways and Means, and Energy and Commerce have to cut. So all they're getting is numbers and targets and without policies attached to it. So they're not going to say, take this much more Medicaid. They're going to say to Energy and Commerce and Finance, take this much money out of your jurisdiction, find $300 billion in cuts. That's where Medicaid gets put on the table. And the things we're looking at is probably rolling back for the Medicaid expansion states, rolling back the higher match rate to something lower. So not a 90% match, for the expansion states of Medicaid. Per capita caps, on Medicaid, been around for a long time. Work requirements. Those are some of the policy things that they're going to use to kind of come up with the savings probably in the Medicaid space. I've not heard anything on CHIP, but that was in the question in the chat as well. But let me just stop there because I don't want to take up too much time on reconciliation.
Yeah, but it's helpful.
That give you enough. Yeah.
Because that's the action that's happening right in front of us right now, and it will have a huge implication going forward.
Yeah. So what we were saying today, just to sum up, is the framework, but not the policy directive. So what we were going to wait for is when Energy and Commerce comes back and saying, here's how we meet our target. We're going to cut this much from Medicaid. That's going to happen later, like a month or two from now, maybe longer. And the Senate's on a much later time frame. But yeah, so what we're seeing now is not something we're going to go and I mean the prevention public health fund's in the mix. That's $1 billion. It's not a lot in the scheme of things, but for us it is. We care about the prevention public health fund that came out of the Affordable Care Act. So that's $1 billion a year that could be eliminated. But that again is something we will rally around later.
So I see a couple of questions around folks who are in red states, folks who are in states that have already experienced some of these issues in their own states, wondering sort of how they can speak up in this environment. I know, there's no easy answers, but I wonder if Dr. Fallon, if you wouldn't mind giving a sense of how you think folks who are in certain areas of the country that want to speak up but are concerned about doing so, if you have any thoughts about that.
Sure. And I would echo things that Boris has already said in this regard. We are each individual citizens who have a right and an obligation to speak up for what we think is the right way to shape our future as a country, right? And so all of us can be acting as individuals all the time. And some schools will have advocacy guidance. ASPPH through Tim's shop has advocacy guidance. APHA has advocacy guidance. And then many other particular professional organizations that might be in areas of research or public health practice that you care about, right? So look into those. They'll do all kinds of things from, the 5 calls that's been sent around to, there's all kinds of actions and activities that you can do that are not solely about your state, that can have applications in other states. But if you are sitting in a red state or a state that has representatives that are part of shaping this, absolutely you have leverage to be able to reach out. So never take that away. Then we also have the privilege of academic freedom. So our faculty, staff, and students have the right to talk about things, even when they're wearing their faculty, for example, labeling, as long as they're clear that they're not talking on behalf of the institution, but they're speaking to their subject matter expertise. And that's another avenue that we locally, and I think many institutions and members of ASPPH are doing, is really putting out our expertise, showing the evidence, which is really clear that a lot of these activities go against what we know is important for public health. And so we got to continue to do that. And then institutions themselves, that's where you may or may not be able to be as vocal as you might want to be, because we are not lobbying organizations, and there are some real reasons behind that. But that shouldn't stand in the way of all the things that I just said before that. What you can do as an individual citizen and what you can do as an individual member of a community that's protected by free speech and academic freedom.
Very, very well said. Thanks. So we are sort of getting towards the end. There's a question about whether or not we're going to have another webinar in a few months, and I think that's a very good idea because, as you can tell, we don't have all the answers. No one does. Someone mentioned that they went to the Hill recently, and even people on Capitol Hill didn't have the answers yet. And that's very much true because with a new administration and new leadership in the Senate, there are a lot of unknowns. So I want to reassure people that we will continue to have these kinds of discussions. ASPPH also has a policy and advocacy newsletter that comes out every Monday, and you can sign up for that at asppph.org. So if you want to keep informed about what's going on in public health as it relates to academic public health, you can get our newsletter. With the few minutes that we have remaining, I think I'll turn to you, Boris, in your role as the chair of our advocacy committee. Do you want to talk a little bit about ASPPH's priorities and what we will be doing? I can fill in some gaps if you need, but give your perspective on what we're going to be doing next.
Well, it's strange, Tim, and I'll turn to you shortly on this, and since you're sort of the architect of from the ASPPH point of view, right? As being humbled to be the chair of the advocacy committee, what we've traditionally done is we've chosen our priorities, right, in normal years, right? And it's always been, we're here to fight for, right, certain programs. We're here to fight for academic public health for the good of our students, first and foremost, for the good of our faculty and staff, our institutions. But at the end of the day, it was really looking at the idea of what were the ultimately the recommendations for budgets of the entities that, the agencies that we hold near and dear, our friends and allies within the NIH, within CDC, within FDA, within HRSA, within other elements of HHS that played a key role, right, in terms of interactions with academic public health. This year, I frankly, as chair of the advocacy committee, and I know we've recently had our meeting, we'll have more meetings in the future about this. These last few weeks make me think of, what is our real strategy at this point, right? It's not business as usual, which means Mark and Tim and members of our committee and others are going to have to focus on, okay, yes, it's still going to be about the budget, but boy, how do we really get to the heart of these bigger matters right now? But talk a little bit about Tim about sort of the specifics from ASPPH, please.
Yeah, I mean, you covered much of it, Boris, but ASPPH, unfortunately, we'd like to usually have a more proactive agenda in terms of what we're pushing for in terms of academic public health from the federal government and working to try to, maybe reform some things in order to, improve the impact that we all could have. In this case, we will be, as Boris said, defending the budgets for NIH, for CDC, for HRSA, and the like. We also are, very concerned about the impact on the research that our institutions are doing from USAID and the actual work on the ground. So we will be talking to members of Congress and the committees that write the funding bills and making sure that they still understand that these are our priorities and that, they're actually an incredibly efficient investment in terms of the economic impact that they can have, both locally, for the people that work at these institutions, but also in terms of keeping our communities healthy in order to be productive citizens. So we will definitely be, focusing on those arguments, and we will probably have to shift some of the ways we talk about things, but our passion and our determination has only increased in terms of trying to make sure we're advocating for all of you who are working in public health and are trying to train the next generation of public health leaders. So
Tim, can I just add, I know we're almost
Yes.
out of time, but I do want to touch on, since this is, Anna happens to be one of my faculty people who asked this question, Dr. Stephen Thomas talks about how will you protect those of us who speak out? And in essence is, I got to tell you, I don't know how we're going to protect, each other than that within our community, there is unity. And the reality is that don't feel like you're standing alone. We are in a very unique time period where all of a sudden the concept of fear, of retribution, of trolling, etc., is real. I don't deny that that's taking place, nor do I have the magic formula. But does that make us shut up? I gotta, I hope we're able to sort of unify around this and supporting each other in being brave in these difficult times.
Yeah, thanks for ending on that note. And, ASPPH will be speaking on your behalf, but it's always more effective if people at the grassroots are also speaking out as well. We are right up at the end of time. I want to thank Dr. Fallon. I want to thank Dr. Leshniak. I want to thank Mark Miandusky for an excellent conversation. It was recorded. We're putting up the QR code if you want to go back and listen to more of this. And as I said, we will continue to have other webinars, and thank you all for participating, and look forward to being in contact with all of you if you have any questions. Thank you.
Thanks, everybody.